Welcome, everybody. Uh, I'm very happy to see all of you here. And thank you, Amy, for being our guests. We are honored to have you here. I have asked Amy to tell us a little bit about her journey, so I don't want to do a long-winded introduction. She is currently the Chief Behavioral Officer at Lirio, and she is the author of the wonderful book, Engaged, Designing for Behavior Change. She warned me against coronavirus jokes for the book cover, so I'm not going to tell any. But anyway, Amy's work focuses on behavioral design, and it's kind of like an evolution of I see it as an evolution of the behavioral design literature in terms of not just designing products that are, and experiences that are addictive in any sense, but also that are positive for the user in a very broad sense. The most addictive thing that she has designed is actually this book. I'm reading it for the second time. So you are warned. If you grab this, you're not going to drop it, okay, until you're done. And Rich is going to put the code for a discount on the chat. And so without further ado, it's all yours, Amy. Thank you for being here.
Oh, thank you all so much for having me. This is really a pleasure. I've been looking forward to this. So just to give a little bit by way of background, I have my PhD in psychology. I finished grad school in 2006. And at the time, if you were going through a PhD program in psychology, it was kind of assumed that you would go on to an academic job. I had decided probably my third out of 5 years that probably wasn't what I wanted to do for a mix of personal and professional reasons. And the big personal one was, I was young, I was single, and on the academic job market, you don't always have a lot of control over where you live geographically. And I really wanted that control over my location at that stage of my life. And then professionally, I loved so much of what I did in grad school, the teaching, the research, but the particular way that it was done wasn't quite jibing for me. I really wanted to be able to do research that had more of an immediate impact in terms of people's experiences. So, essentially getting something into a product out into market. So I was very lucky to, first of all, my first job search was terrible. It was really, really hard to find a job that a PhD in psychology, brand new, newly minted PhD, was eligible for. But I did find a job doing research for an agency that was focused in healthcare. And while the job itself didn't tick all my boxes, working in healthcare did. Because it's really an area where there is so much impact of people's individual behaviors, and so much need for support in terms of forming healthy habits, helping people set realistic goals, tapping into motivation. So I learned in that first job that healthcare was going to be home for me. And then my second job was with a startup called Health Media that had a digital health product that really focused on personalizing coaching for people through technology. So very scalable. And that was, for me, that was it. Like, that was the job that checked all my boxes. And I really started to become a behavioral designer. Before that really had a name to it. So at some point in the last, I would say 5 to 7 years, I think behavioral design has really become its own subfield. Like, there are people who do it now. There's people who have it as a job title. But for the first good chunk of my career, I was kind of doing this offbeat brand of design under whatever job title would take me. So I've been, a behavioral scientist. I've been a strategy manager. I worked at CVS Health for about a year, and I was a strategy manager there. I did end up at MadPow, which is a strategy and design agency, for about 5 years, working in their behavior change design function before I came to Lirio, where I was initially the vice president of behavioral design. And then early this year, I was promoted to be chief behavioral officer. So I now oversee both our behavioral design team, which includes content designers and visual designers, in addition to social scientists like myself, and then our behavioral research team, which is really focused on doing some of that actually more academic caliber research. So in a funny way, I've come back around home to where I was trained and the type of work that I learned how to do way back when. So it's been a fun adventure for me. It's been a lot of identity shifts, as well as what I do has sort of gained a name and gained recognition. And I've had a community form that I'm now part of, which is pretty amazing to me. But I absolutely love it. I love talking about it. And I especially love talking to people who are in the middle of their education, because I think there's so much opportunity in terms of the careers available to you that's new, even from 15, 16 years ago when I graduated. So with that, I am going to talk about behavioral design. And if you've read my book, you'll recognize a lot of what I'm talking about. But I hope that the conversation and presentation is nonetheless interesting and engaging. And I will monitor the chat, and in particular, if you have clarification type questions, I'll make sure that I answer those, because I certainly don't want people not following along because I've used jargon or something and confused you a bit. All right, so how do we design for behavior change? I'm going to talk about process, but I am also going to talk about a couple of the theories that I heavily draw on and bring into my work, so that you can get a sense of the flavor of the behavior science content that I use. I did add in, I'm using, as you can see, Lirio's slide template, and I did add in a, oh, my thing isn't advanced. There it is. Just briefly to tell you what I actually do day to day now. Lirio is a behavior change AI company. So I work really closely with artificial intelligence scientists, which is amazing to be able to collaborate across scientific disciplines. We're focused in healthcare. We specifically work primarily with health systems, and we create behaviorally informed messaging that is designed to get people to take action around their healthcare. So for example, getting preventative screenings on the recommended schedule, or seeing their primary care physician on the recommended schedule. We're primarily reaching out to people who haven't been engaged with their healthcare, and we're trying to connect with their motivation to get them to take action. So it's really right in my wheelhouse. And, I'm learning so much with all of the exposure to artificial intelligence that I hadn't had before. So why behavioral design? And I like to start with, to get people to change what people do, we have to understand why they do it. And when we know what makes them tick, why they do what they do, that's when we have the ability to design interventions that will engage them and ultimately support them in changing that behavior. Intervention is one of those jargony things. So what is an intervention? These are all examples of interventions. They're products, experiences, or communications designed to get people to act differently than they would otherwise. Essentially, anything I build as a behavioral scientist that I'm putting out there to affect people's behavior, the terminology for it is intervention. So you'll hear me say that a lot, and it's kind of a generic catch-all term for anything that we build. I'm also going to talk a lot about engagement. And one of the most useful things that has come out in the last several years about thinking about engagement, and something that's really informed my perspective, actually came from my former team at Johnson & Johnson, although it was after I had left the organization. And it's thinking about levels of engagement. And they actually termed this big E and little e. So little e is engagement with the intervention itself. It's engagement with the design elements of it, with the user interface, the UI. Or with the functions of it. So if, for example, there is an activity tracker that is part of the intervention and somebody really is engaged with using that activity tracker, we would consider them engaged in a little e sense. The big E sense is engaging with the behaviors you want people to change. And if you think about, designing an app, I probably shouldn't have said step tracker actually, because if you're engaging with the tracker, you're probably also getting steps. But there's an opportunity a lot of times for someone to engage with the product without necessarily doing the behaviors that it wants you to do. And if that other piece is missing, that big E, then you're not going to have the outcomes that you're looking for. So when I'm thinking about behavioral design, I'm thinking about both of these layers. I really want to create a system, a circumstance where people will engage with the new behavior, but I also need to deliver that engagement in a package that is itself engaging. So I've got to hit the little e and the big E. And one of the things I love about thinking this way is it creates so much opportunity to collaborate with other design disciplines. So, my team at Lirio includes content designers, visual designers, UX designers, and I really need their partnership in order to create that experience that people will engage with. And then one last sort of foundational slide, the process. And I did create a little legend that you'll see on some of my other slides that show where in this process I'm talking about. I'm going to go through somewhat linearly, but our behavioral design process is really, we research based on what we learn, we design. Then we work with our colleagues to build something. And then finally, we test. We want to measure that the things we're building are working. And I've always struggled with how to present this because it's not really linear. It's that test has lots of little loops throughout the whole process. We're making prototypes, we're doing beta testing, we're surveying potential users or patients throughout the process. And even if we do a big sort of outcomes study and measure, does this thing actually work in the real world? Ideally, we're taking whatever we learn from that, bringing it back into the product environment and continually improving our approach. But for simplicity's sake and the first time through, it does kind of go in this linear fashion, and I will talk through each of these steps in more detail. So where do we start? We start by defining our target outcomes. We really have to start at the end in order to know what we're building here. And it's a little counterintuitive when you're first getting into this area, but you really have to have that endpoint in mind in order to create your navigation. So this is actually an illustration from my book, but it's something called an outcomes logic map. And this is something we build when we are beginning to work on a project, and we build it right to left, even though we read it left to right. So the first thing we start with is trying to understand the long-term outcomes. What is the purpose of this project? What are the key performance indicators or KPIs that we're hoping to achieve? And then working backwards from there, what are the behavior changes that need to happen in people in order for those outcomes to come true? And then even before that is this box here called participation and engagement. That's our little e. How much do we need people to engage with the intervention in order for them to get what they need to change those behaviors, whether it's education or tools that support the new behavior, feedback, coaching. And then the very first box is baseline measurements, because if we want to be doing this constant testing and understanding the effects of our intervention in the real world, we need to understand where we're starting from. We need to be able to measure a delta. So really, it's all going to hinge around these behavior changes. We have to define those long-term outcomes first in order to know what we're hoping to achieve. But it's the behaviors that are going to bring those outcomes to life. And therefore, it's the behaviors that are the target of our design efforts. I won't spend too much time here. This is also part of the book, but I did flesh out, and by the way, this is as much as this looks a little complex, this is overly simplified, but just to show the types of things that will go into each part of an outcomes map. Usually long-term outcomes, there's something financial. In the commercial space, most people want to see some sort of positive return on investment for the technology that they're investing in, and makes total sense. In the health space, we're usually looking at some sort of actual health improvement. So that might be something like, people weigh less, or their cholesterol went down, or they're not having as many heart attacks. We also in healthcare, a lot of times are looking at healthcare utilization. So for example, you might want to have people use primary care, which they're planning for and has sort of a known cost attached to it, versus urgent care or emergency room, which is typically more expensive, and fluctuations in people coming in that can be very hard to staff for as well. So things like that. In terms of behavior changes, a lot of times it's, going to your appointments, taking your medications, doing your lifestyle behaviors. For the little e, we're often measuring those digital engagement metrics. Are people downloading the app? Are they logging in? How often are they logging in? How long are they using it for? And then whatever we're measuring in terms of those other outcomes, we do want to have the corresponding baselines. All right, so we're designing around behavior. We got to actually define and prioritize them, right? We call them target behaviors. Our goal is to identify those target behaviors, map them out, and then smooth the action paths. We want to make it as easy as possible for people to succeed. So this actually represents the process that we're using at Lirio. I think it's generalizable to other contexts, but I did include a few things here, knowing that they are specific to our environment, because I think it's helpful to ground it in the actual work that an organization is doing. So we do stakeholder research. We talk to people who work at our client organizations in all different types of functions to really understand what the behavioral experience is like from their perspective. Someone who runs the patient call center is going to have a different point of view from the person who is staffing the clinic, from the doctor who's providing the care. And if we talk to people who belong to each of those groups, we can start to get a nice 3D picture of what that behavioral experience looks like and where there are pain points. Reviewing artifacts, anything that patients are actually interacting with, we want to review that. And again, understand where they may be experiencing friction, where we can help design a smoother experience. If available, listening to patient calls, like if there's a call center helpline sort of thing, sometimes we're able to actually listen to recordings. And typically, I'll just mention, because I think it's sort of interesting, the organization will actually sanitize those calls. So they'll do things like bleep out the patient name. Like, we're not being exposed to individual patient information there. So if you're worried about that, from all of us are patients too. Technology demos or sample accounts, actually using the technology that patients use, reading patient feedback. So if you ever fill out a survey after you've received care, Health systems aggregate that, they keep it. So we'll review those sorts of things and see, like, are there points of consistent dissatisfaction or satisfaction in your patient population? And then, of course, direct patient research as well, whether that's interviews or surveys or, observing them in their natural habitat. I mentioned before that we're targeting behavior. A question that does come up sometimes is why behavior, because the way that we feel and the way that we think can also matter a lot in our experience and our behavior. And that's true, but ultimately it's typically the behavior that drives the outcomes. So it's kind of a different way of presenting what I shared with the logic map here. We may, with our interventions, affect how people feel, their affect, or how they think, their cognition, but we expect that to manifest in changes in their behavior. If we were simply creating an intervention that made people happy, that would be very unlikely to lower healthcare costs associated with, say, cancer. So it may matter a lot. We may want to reduce people's fear, increase their interest in feeling good about getting a cancer screening, but there needs to be that behavioral step for it to ultimately translate to outcomes. So that's why you'll see this constant focus on behavior, even though it's not the only aspect of our human functioning that matters. So we go through a behavioral design and discovery process at Lirio. I just mentioned in the bulleted list the things that we do, but you can see here, we actually map them out using Mural or Miro or a similar kind of visual system so that we can align what's going on here. And then ultimately what we end up with is this sort of action path mapping where we're saying this is what the patient goes through step by step. Here's where there's points of friction. Here's where there's points of opportunity for us to apply behavior science to improve the experience. Jason, I see you have your hand up.
Yeah, actually, I just have a quick question about your 2 slides back, and it was just something that you said about this behavior piece, and you touched on something about satisfaction, being happy, cancer patient, but does that actually change the outcome? And it strikes me as this seems to be a bit of a blind spot in the healthcare system, in that there's always these kind of patient satisfaction surveys, and it puts physicians in a bit of a bind, especially in these health management organizations, that if they're trying to promote behavior change, as in healthy behaviors, but the worker or the patient is not feeling supported, they could get a lower score, right? So I'm just wondering about your thoughts about how to reconcile that. And maybe that's something that you're going to get to, but just like high level, I mean, we have the saying in the work that I do is that customer service is not a proxy for engagement. And it seems like you're kind of talking about that, but it's a hard thing to kind of wrap your head around, because the natural thing is to provide a better experience, but that doesn't necessarily lend itself to the actual outcome you're looking for.
Yeah, and actually there's a really specific example from healthcare. There's a survey called HCAHPS that is administered after somebody has an inpatient stay. And scores on HCAHPS matter a lot for health systems. If they don't score well enough, they are not reimbursed as well by CMS, by the Centers for Medicaid and Medicare Services. So they're really motivated to maximize their HCAHPS scores. But they measure patient satisfaction, and there were a series of questions on there about pain management, where it was like, my providers were responsive to my complaints about my pain, and I was given help to manage my pain quickly, something like that. But they found that that was actually inadvertently fueling opioid use in hospital settings, because opioids are very, very effective at managing pain. And they do it quickly. And so providers were able to kind of maximize that HCAHPS score if they gave somebody an opioid, where that may not actually be the optimal way to manage pain. And there was some correlational research showing that correlational, and like obviously lots of other stuff was going on around the opioid epidemic in the US at the same time. So I wouldn't blame HCAHPS for opioid abuse by any means, but it was associated with an increase in opioid use in the areas where hospitals were using that. And those questions have actually been removed from the HCAHPS survey. So I think it sort of speaks to, in that case, it was trying to provide that customer service, but it was not necessarily in the benefit of the patient ultimately. So yeah, it can be a really tricky sort of thing. So yeah, thank you. In terms of target behaviors, as we try to understand the patient experience and what might lead to outcomes, sometimes you will get sort of a laundry list of possible target behaviors. And so an important thing early in behavioral design is to prioritize those and select just a handful to design around. rules of thumb, which ones are actually going to lead to the outcomes at hand. So which ones have the strongest connection to, financial improvement or health outcome improvement? Do you actually have the ability to change those behaviors? Then that's both like, do you have access to the people who do it? You might have been engaged to create a patient-facing app, but you don't have the access to physicians. And if it's a physician behavior, well, you probably can't do anything. And then do you actually have the toolkit to affect that behavior? So, that HCAHPS and opioid example might be one where we might be called into, and when I say we, I'm using the broad sort of like royal we here, behavioral designers. Can you help us with opioid behaviors? And it's like, well, if the HCAHPS survey is still in use with those questions on it, there's only so much we can do. Like, we're working with that constraint. One of the things I'll add for Lirio here, working with artificial intelligence that I've had to adapt into my practice is for our AI to work, we actually also have to have objective behavioral data. We have to actually know if somebody took action or not. So that's an additional element that I look for now when I'm selecting target behaviors. Will we be able to find out definitively if a patient took this action or not? So if it's something like a 10-to mammogram, there's a really clear behavioral indicator that happened, and that ultimately is usually a good target for our work. And an example of one that might be a little squishier, even though there is data around it, is something like weight management. Did this person lose weight? Because, then you have to, okay, where are they recording this? Where are we getting the data from? Is it reliable data? Where that appointment attendance is pretty straightforward and binary. Defining target behaviors is a lot like defining goals. So if you've heard of SMART goals, the specific, measurable, actionable, reasonable, and timely. Similarly here, we want to be really specific and measurable with what we name as target behaviors. So things like get healthier or protect yourself from COVID-19 are really vague to design for. They could mean a lot of different things to different people. Or something like complete a wellness visit with your primary care physician every 12 months, or get a COVID-19 vaccination are super clear. And just as an example, at Lirio, when I first started, we built a program for colonoscopy, and these were our target behaviors that we determined we would design for. So scheduling the colonoscopy, arranging for transportation to the colonoscopy because they give you anesthesia. In most states, you are not allowed to drive yourself to and from. Obtain your prep materials. There's laxative prep leading up to the procedure. Actually doing that prep in the day before the procedure. And then, of course, attending the colonoscopy, getting to the finish line where the procedure is done and now it's in the past. So these are the specific targets that we've designed around, and they're the specific targets that we measure to check that we're actually effectively changing behavior. So I use a model in my design to do all this called COM-B. I talk about it quite a bit in the book, and we leverage it very, very heavily at Lirio. It helps us to identify specific barriers and facilitators to the behaviors that we're trying to promote, those target behaviors. And the broad catch-all term for this is determinants. Behavioral determinants are both barriers, things that make the behavior harder, and used to talk about these things. So anything that adds friction is generally, but not always, undesirable. Sometimes you do want people to slow their roll a bit and be thoughtful about the behaviors they're about to take, in which case some friction can be a good thing. And in general, fuel when it's towards a desired behavior is a good thing. So COM-B helps us think about these. Oh, hold on, question?
I have a really basic question.
Yeah.
So insurance tends to be built, especially on the lower end, toward creating friction toward many of the behaviors you're trying to get people to do. How do you build that into the COM-B model, and how do you deal with the fact that people are lousy at dealing with things like Your Friends and Mine United?
Yeah, well, I don't have a great answer. I have done a lot of work with insurance companies, and I agree with you. Their processes generally do not make things easy on patients. And I think that in many cases, there's two things going on. Either they have legacy issue, well, both. I think both are actually going on simultaneously. So one, legacy issues. They're working with older systems. A lot of these groups have grown by acquisition. And so they're dealing with multiple different technology systems on the back end that don't speak to each other. And so, I can't just log in and have it automatically know my information. I have to keep entering the information over and over on different forms, that kind of thing, where, it's maybe not what they desired, but it's kind of the way it is. But I think the other thing is they have a goal that is different from patient goals. And this is a case where you're seeing those two goals butt up against each other. So, patients want to receive their care and they want to pay I'll call it a fair price, like just, and insurance companies want to make money. So they have goals that are in conflict with each other. And so when I've done projects with insurance companies, typically they have a really clear boundary around them. It's not, redesign our whole system so it's easier for patients to pay for their care. It's typically something that's really, really specific, like, patients aren't taking advantage of this one program that we offer. Can you make it easier for them to take advantage of this one specific program? And when you're working within those kinds of constraints, of course you can help, you can make a difference. But I think you're speaking to like kind of a larger systemic problem that I wish we could solve. So sorry, I know that's probably not quite the answer you're looking for, but.
No, it's good. What you're speaking to is how you build a model and the limits of your model. And that's okay.
Yeah. I will say though, COM-B is part of a larger model called the Behavior Change Wheel. It comes out of the UK. So behavior spelt with a U if you want to Google it. And the larger model is actually used in some contexts, including influencing policy, like government policy. And in fact, you probably know a lot of governments, including the UK, I think they were the first, have behavioral insights teams, that nudge units that were specifically built to help people comply with policy, things like paying parking tickets and not littering. So there is this sort of history of using this model outside of the healthcare space, and I think looking at more systemic sorts of issues. But the US health insurance system is kind of its own thorny beast that I don't think anyone's really solved. That said, this is the model. So COM-B is an acronym. B stands for behavior. We've defined our target behavior. So that's what we're plugging into that box. And when we think about the determinants of the behavior, we are able to classify them as belonging to the C, the O, or the M. So capability is either your psychological or your physical ability to do the behavior. Psychological ability is has a little bit more under the hood there, because that includes things like memory, understanding how to do it, being able to regulate your attention and your activities, perhaps in a busy environment where, you need to remember step by step this complex behavior. Physical ability is exactly what it sounds like. Motivation includes reflective and automatic motivation. Reflective motivation is probably what you think of when you hear the word motivation. So it's your goals, and more interestingly, it's your priority of goals. So most people will say like, yeah, I want to be healthy. I want to do the healthy thing. And they do, but they also want to do a lot of the unhealthy things too. And so it's which one wins out in your day when you're making your decisions. And then automatic motivation is really about your mental models, the way that you understand a behavior and its meaning. And so things like your culture, your upbringing might really influence your automatic motivation. This one's always so interesting because people aren't always aware of their own mental models. It's not something that's easy to introspect on, and not everybody is sitting around, oh, what do I think of mammograms and their value in my life? So as a researcher and a designer, that one can be really interesting to dig in on. And then opportunity is about the environment, both the physical and the social environment. Social environment being other people. They are out of order of the acronym in this graphic on purpose, because opportunity and motivation can affect each other and have some overlap, and capability and motivation affect each other and have some overlap. So you'll see the arrows in the middle there indicating that. So how do we actually use this? I use this a lot in discovery research. So this is something when we're doing user research or even stakeholder research, we will ask specific questions around the behavior to try to unpack what in each of these categories is making this easier or harder for you. So I like to start at a top level, and I love to have people tell me stories, just as a general research tip. There's a great oral tradition in humanity. That's how we communicate with each other, how we remember things. And it's the way that some forms of education still work. Business schools and medical schools rely really heavily on the case method. So I love to ask people, tell me a story about doing this behavior. What's it like for you? Let's go back to the last time you went to the doctor. Walk me through, tell me about it. And I actually really like to let people go on for a long time without asking a lot of questions. And I'm doing very active listening during that time to try to pick up on the things that they're saying might have made it easier or harder for them. Some of the follow-up questions that I might ask, and especially if they don't touch on these things, is, ask them to actually reflect on what made this harder for you or easier for you. Or if I really want to dig in on a particular aspect of the COM-B model, I can ask, what made that physically hard for you? Or, what about the physical environment where the behavior may happen? Like, was it hard for you to pick up an exercise habit since you live in an area with really windy roads and no sidewalks? Or like, what was that like? So, there are sort of more specific probes. We also always do literature reviews as part of our process at Lirio. We don't want to reinvent the wheel, and especially in the types of health behaviors we deal with, there's typically a pretty good body of research that already exists out there. So, we're looking at the peer-reviewed published literature that you can find on like a Medscape database or that sort of thing. And the types of questions we might ask, they're more academic versions of the questions you'd ask somebody in an interview. But, what are some of the factors that are related to doing the behavior or not? If we know what those behavioral determinants, the barriers and the facilitators are, what are some of the factors related to whether someone experiences those? And then we look at what sorts of solutions have worked in the past, because again, we want to build off of what's been successful, and innovate in the white space instead of reinventing the wheel. For our colonoscopy program, by the way, we did find that there were 24 unique barriers that we were able to find using the COM-B model. And then when we kind of grouped similar ones together, it ended up being 11 barrier constructs. But this really became the foundation of our design. And when we created our messaging library, this was what we anchored it on. And then just like we prioritize target behaviors, we also prioritize barriers, because if you're working in a commercial environment, especially, perfect is the enemy of good. You want to really make sure that you're putting a strong foot forward, but you also probably can't design for every single problem that's out there. So we go through an organized process. This is described in some detail in my book, but we actually use a spreadsheet. We have each barrier, and then we rank it on, how prevalent is this? What is its impact? Is this really, really getting in the way of people doing the behavior, or is it something that's like a minor annoyance once in a while? And the more that it's prevalent, the more that it affects people, the more likely we are to include it in our design. Once we've done that, though, once we come up with our list of barriers that we're going to design around, it's time to design. Yay. I think this is one of the most fun parts of the process. And again, this is still using that COM-B model. So I meant to animate this, I'm sorry, because it really starts with the person and the barriers that get in between them and the behavior. And what they're going to experience in the intervention is what we call behavior change techniques, or BCTs. So these are the actual features that are intended to change people's behavior. And something like an activity tracker, that's an example of a BCT. Above that, the bars that you see, intervention functions, those are more like categories. So I will share with you what the intervention functions are, but if you think about education, that could manifest in a lot of different flavors, different BCTs, but they all ladder up into that category of education. So when we're thinking about doing our design, we've done the research first to come up with these barriers and really understand what they are. And of course, defining the target behavior. The next step is actually figuring out these intervention functions, and then we can start doing the design on those specific features, the BCTs. So the intervention functions also come from COM-B. There are 9 of them. I'm told that there's going to be a new edition of this in the relatively near future that will include another intervention function around motivation support, which isn't called out specifically right now, but this is what they are, and these are some of the examples related to health. I'm not going to go over all of them, but this is where coercion comes in. So if you've been coerced into being here tonight, I apologize. I actually really try to avoid coercion in my design. There's a lot of evidence that unless it's applied really well and carefully, it can backfire, as you can imagine. And it just doesn't really jibe with some of my training as a motivational psychologist, where it's really important to give people that autonomy and choice over their experience. But it does exist, and you can think of something like those civic applications in policy, where something like a fine or a penalty makes a lot of sense. The ones that I will quickly touch on, because they're not as obvious, restriction, first of all, so using rules that make the behavior harder to do. The example here is about restricting sales of antihistamines without an ID. There's also really great evidence that when cigarettes are taxed at a higher rate in a state, the smoking rate in that state drops dramatically. So that's another example of restriction, where you would use taxes to make it more difficult for somebody to obtain the product. Environment restructuring is really, changing the environment to make the behavior easier or harder to do. I will say when we're designing for this, because we rarely have the opportunity to go into someone's environment and physically change something, it really becomes more like coaching people to do their own environmental restructuring, but it can be very effective. And then enablement, this one has sort of been the catch-all where it's like anything that is more than belongs in any of the other categories, but you can see some of the examples here, like surgery to reduce obesity or assistive devices like tools, coaching, really more intensive support that helps people with the behaviors. And the way that we select them is we've done our research, we know what our barriers are, and Combi has this great research that links solutions to barriers. So, I mean, at this point, it's like following a flow chart. Okay, there's psychological capability issues for people with performing this behavior. Let me look. Education, training, and enablement are really effective at supporting people through capability barriers. Let's make sure that there are solutions that fall into those buckets in our design. It's a really good way to ensure that the ideas that we come up with in our design process have some kind of evidence base to them, like some kind of reason why we would choose them beyond the designer's whim. So yeah, it's really important to me that we're always incorporating that evidence base back into our work. And then once we've done that, once we've decided on our intervention functions that we're going to use, it's time to get into the really fun creative part, which is using those behavior change techniques. So I always, there's 93 of them according to the most recent research. I always show this version first where I cover it up because I don't want people to get too distracted by the fact that there are 93 of them and they're, it's a big list. I love to use this with my team more as a thought starter and go from there. But we do ultimately choose from this list. And this is a taxonomy, so it's intended to be inclusive of pretty much everything that's already out in the literature. It's very comprehensive. And you can find versions of this pretty easily online. The behavior change wheel team has been awesome about making sure that their materials are really open source and shared widely. There's also a group that came out of that same research partnership that built this tool called the Theory and Techniques tool that my team uses quite a lot. And we're working internally on our own version of this that uses our data. But this is an interactive tool. It's online. So the URL is there, theoryandtechniquetool.humanbehaviorchange.org. You can actually see by looking at the colors where there is evidence that a particular behavior change technique works in a particular type of situation. And so we will often use this and ensure that we're choosing behavior change techniques that have that evidence base. We are pretty certain based on previous research that this is going to be effective. And then a very small smattering of ones that we choose where there isn't a lot of evidence yet, because that's the opportunity, right, to gather evidence and data and learn something new. So I would say we do like 90% places where there's already a proven relationship and maybe 10% places that are a little bit more experimental, but we have a strong hypothesis that this is worth looking at. And then the last thing I'll say about, Raphael.
Yes, just a very quick question. I mean, something that you emphasized earlier is that what makes people tick is always different, right? So different. So could you, at this stage in the process, could you give us an idea of standardization versus customization of the design? I mean, and what's the role of data in
Yeah.
Yeah.
Yeah, and I'll talk about this through a Lirio lens because this is how I think about it every day. But we're actually building broad with our libraries. So when we do our research around barriers, we really want to be inclusive of a broad group of people, and we're making some deliberate effort as well to ensure that we're capturing diverse populations because we want to deliver health equity. A lot of times, digital health tools tend to, like, especially if they involve a wearable or something that's a little bit expensive, you'll find that they don't achieve health equity, and that may be fine, but in the type of environment that we're working in, that's really important to us. So we are building probably larger sets of material than we may need. But then what we're doing with our AI is we're trying to match the individual to the right message. And we are also trying to account for how each individual person might change over time. So it's not just that people are different from each other, but we're also different from ourselves over time. And one of the examples that we run into in our work all the time is like the first time someone has, a mammogram or a colonoscopy, they may have barriers around fear of the unknown. I don't know what this is going to be like. I've heard horror stories. It's going to be so embarrassing. And then the second time they may have different barriers because now they've experienced it firsthand, and it's not fear of the unknown anymore. Maybe it's fear of the known, but it will look a little bit different. And so part of what our AI is helping us do is actually match the person to the message And I have really resisted reporting, for example, like this is the most successful message in our library, because it may be that this message works for like 60, 75% of people, but that still leaves 40, 25% of people who aren't responding to that. And the purpose of building the broad library is, even if it only works for one person, we want to have that message that works for the one person. So that's one of the ways that we're trying to build this like large standard library, but then what each individual experiences within it is customized. And then there's also other opportunities, not just with what we're doing at Lirio, but I think with design in general, to give people choice and opportunity to shape their own experience. So I will share a couple examples of that in a few minutes. Cool. All right. Last thing on COM-B though, and another reason I really like it is when you get into that BCT level, there's still a lot of room to make creative decisions in terms of your design, and as a behavior scientist, to bring in theories, frameworks, tools that you think will really create a better experience. And so I mentioned, I think of myself as a motivational psychologist or a motivation psychologist. I rely on theories of motivation a lot in my work. And if I get into something like these behavior change techniques around feedback and monitoring, there's a lot of room to think about motivation. So how do I deliver feedback in a way that is motivating and not demotivating to somebody, that helps them feel like they're making progress? I can also think about self-efficacy. I can think about cognitive behavioral therapy. I can think about the health belief model. There's all these different ways to layer in additional and deeper perspectives on the behavior. And I really like that, because so many theories and approaches are like, this is the way you do it. This is the only set of tools in your toolkit, where I feel like COM-B gives me a really nice basic structure to work from, but then also affords me the ability to bring in other tools, other approaches in a way that makes sense, and helps me collaborate, frankly, with other types of behavior scientists and other cross-functional team members. So in terms of going beyond COM-B, this is just a partial list of health-related behavior theories that I've put together. I don't use nearly all of these. Some of them have fallen out of vogue. And you do also find, by the way, that these approaches will be popular for a period of time and then fade away and then sometimes come back. COM-B itself is about 10 years old. Self-determination theory, which I'm about to talk about, is about 40 years old, which is, that's really good longevity in this area. And one of the reasons I do like that theory too. When I'm thinking about this, though, I've really grown into the metaphor of a road. So health behavior, right? It takes place over the course of a lifetime. There's lots of episodic behaviors that we need to do. We need to go to the doctors or, have that cancer screening. But day to day, we're making tens, if not hundreds of choices that affect our health. And there's no intervention on earth that can really be with you for every single one of those choices, every single one of those behaviors. So when I'm designing, I like to think about it in two ways. I think about nudges. So coming from behavioral economics, and I'm not going to talk a lot about these because I did assume that, many of you being in the behavioral economics course and knowing what you do, that this would be something that I'm not going to enlighten you as much as you're being enlightened every week. But really thinking about those as features in the choice architecture that make a particular option more likely than another. If you're driving down a highway, in this metaphor, the nudges are going to be things like the exit sign, and maybe even more importantly, the sign right before the exit sign that tells you that Chick-fil-A and Burger King are off this exit. So in that sort of moment of decision making, they are what push you towards one decision over another. Behavior change techniques, which I've just talked about, I really think of those as well as potentially doing that, but also potentially being the thing that keeps you on that road in between exits, because sometimes it may be 30, 40 miles until the next rest stop, and you still need something to keep you on that road. And that's where we really need to tap into something that's a little bit more intrinsic to the person, that they carry with them, and they don't rely on our intervention to supply. So I'm just going to pretty briefly talk about self-determination theory and why I use that, but it's really about helping people connect to their purpose and their reason for staying on that road of behavior change. Two big concepts from self-determination theory. So by the way, selfdeterminationtheory.org, if you are nerdy about this stuff, it's a great resource for learning about this. But the first big piece of it is it's not really about if you have high or low motivation. It's not about the amount. And in day-to-day conversation, that's how we talk about it. But in reality, it's what is the source of your motivation? What is making you tick? And we all experience all of these, absolutely. And sometimes we experience more than one of them at the same time. But the more that we're motivated by the things that are on the right hand under autonomous, the more sustainable that is. These are things that matter deeply to me as a person, that I carry with me day to day, situation to situation. And if I can help people tap into that with my design, then they will be less tempted to fall off the wagon, so to speak, with their behavior if things get hard. Where if they're only doing something because their doctor told them to do it, or, my spouse expects me to do this, it can be kind of easy to slip up or to cheat if it's not something that your heart is in. So the first big thing I want to point out here with designing with motivation is it's really important to ask people to try to understand, using whatever clues are available to you, what really matters to them. What are the big G goals that they have, their life goals? How do they think of themselves? What's their identity? People, have values. They have things that they would be very disappointed in themselves if they felt like they weren't living into. And if we can understand that and start to talk about behaviors in that context, we're much more likely to connect with them in a way where they carry that behavior forward. Yeah, Rich.
So, I had a similar question to Raphael, but this might be a good time for me to give you my version of it. Is that if you're going to get to the big E, I didn't read the book, but I read a bunch of your papers. And if you're going to get to the big E, intrinsic motivation is, paramount, I would assume, right?
Absolutely.
So how does AI help you to customize the interventions to, I have to assume that working in this field gives you a really good opportunity. I mean, compare contrast with your previous role to working with AI. How does it really let you get there?
I think it does. It takes some time. That is a disadvantage of AI. It doesn't understand a person on day one because it needs to see how they behave, see how they react to things. Although we can do things. So one of the things that I have learned is that there are, and I'm sorry, this is so fundamental. There's probably some of you who are gonna be like, yeah, of course you've learned this. Different types of AI. So there's things like recommendation engines, like Netflix, where you log in and it's sort of like based on what you've watched before and what we want you to watch. This is what we recommend. We're doing a particular type of AI called reinforcement learning. So it's training off of people's behaviors, and we're actually setting reward functions around that. So whatever those target behaviors are, get the highest reward if the agent is able to get people to do them. And then there's lesser rewards for things like engaging the little E. The little E gets the little rewards, the big E gets the big rewards, is how we build it. And so I think that is actually one way that the AI is able to help us get there, because it is learning not to maximize on the little E. And I think something like a Netflix, a recommender engine, is very good at maximizing on the little E, because Netflix wants you to spend as many hours as possible on their platform. And ideally, they want you to be consuming the content that they produced, which is lower cost to them, right? It all gets back to some of their corporate goals, where, with the big E, we don't care if you read every single one of our emails. We care if you go get your mammogram when your doctor says you should have your mammogram. And so the algorithm, I think, is very, very good at starting to figure out what are the types of messages, what are the types of behavior change techniques that for each individual is likely to get them to that big E. And one of the cool things that the AI team has been working on that I truly don't understand a lot about beyond what it does is, transfer learning, where the AI can learn something about a patient in one context, like say me in a mammogram, but then later on when I need my primary care visit, it's already learned something about me, and it's smart enough to start to tease out that the primary care visit and the mammogram might not be exactly the same to me. They may not carry exactly the same barriers and require the same touch, but there's still something about me as a person that carries through both of them. So as a human being, that would be really, really hard to do in a scalable way. And the AI makes it much easier to do. All right, I'm going to just quickly touch on the second piece of self-determination theory here. Yeah, the old Netflix algorithm was way better. I really think them producing their own content had a lot to do with it getting worse. Okay, so the second piece of self-determination theory is that we all have basic psychological needs. And if we want to connect people with those autonomous forms of motivation, the things that matter to them, we need to design to support these basic psychological needs. So this is where the sort of design power of this theory comes from. The three of them are autonomy. So people want to make their own meaningful choices. And this gets back to why I don't like to use coercion. You can definitely coerce somebody into doing something on a short-term basis, but ultimately that's usually not effective at keeping them doing it long-term. And part of it's because they don't get to express their autonomy. They're likely not doing something because it aligns with reasons that matter to them. There's competence. So we're all looking for signals in the world that we're learning and growing. I've used the metaphor before of like throwing a stone into a pond. We want to see the ripples it creates, and we get kind of freaked out if it just sinks without making any dent in the surface. It's really similar with our behaviors. And, even think about talking to people. Human beings are so sensitive to others' facial expressions and reactions. We're really built to see what our effect in the world is and to crave this constant sort of growth and progress. And then relatedness. So feeling like you're part of something bigger than yourself, like you belong. So all of these things are really, really important. And as we design our interventions, we have opportunities to either support these basic psychological needs or not. The more we support them, the more people will feel interested in using our intervention. And the more we have these opportunities to help them see behaviors aligned with what really matters to them. Just checking the chat. It's just people hating on the new Netflix algorithm. I'm watching the time. I don't want to go more than, say, 10 more minutes before making sure we have plenty of time for questions and conversation. So I will just really quickly talk about a couple of ways in design that we can support each of these. And again, if you do have or are interested in my book, I give a lot of examples. I actually used these basic psychological needs to structure the book. And I have, I think, at least 2 chapters for each of them that goes into kind of a sub way to support. So this is something I have a lot of content on. But I do want to start with talking about meaningful choice, and I'm going to hate on myself a little bit here. So one of the things that I've found in design is that it's really tempting, and for myself included, to be like, any choice is good choice, right? Like people want choice, and that's not necessarily true. So on the left here, My Coach Sleep, that's a product that I worked on when I was with J&J. I am very, very proud of that work. It was a great product. We did a randomized control trial with it where it outperformed sleep diaries, which are a standard of care for improving people's sleep after 3 weeks. Like people who use this tool were sleeping, going to bed on time and sleeping better, all that good stuff. But what you see here with the cityscape was a design feature we were so proud of. You can see these little numbers down the bottom. People could choose any one of 9 backgrounds. We spent so much time, so much time on that. And we're like, this is so cool. People are going to be so excited to choose their background on their homepage of My Coach Sleep. Yeah, it was cool. Is that meaningful choice? Absolutely not. So if I could go back then with what I know now, I probably would recommend against spending so much time on this feature, as cool as it was. I always use the cityscape. That's my screenshot. There was like a kitten and a puppy and a field of flowers and all kinds of nice photos. MediSafe is another example. This is a medication adherence app. And if you want to change the color of the background, you have to pay for a subscription as opposed to having it free. Like that, not meaningful choice and probably not driving a lot of subscription. There's also letting people pick goals. And this is really tricky in health, especially because there's often like a right thing to do, right? Like if you want to lose weight, the basic recipe is less calories. And that's not always easy when you're trying to let people have choice. But a way that you can get around that is by having them frame the upper level goal. And Pacifica has been acquired and renamed, and I always forget the new name because it is not catchy, but it's a mood management app that's very good, and it lets you set your goal when you join. It's not just I want to manage my mood, which is what it's for, but it's like I want to be less cranky at my kids. Noom also does a great job at having people set their goals when they join, and they use a project management technique that I think also has roots in therapy about the 5 whys. So it asks people to set their goal, and then it's like, okay, but why really? Like, what really is your goal? And it basically keeps asking you until you distill it down to the most essential goal. But it's this process that really gets people to think about, why am I here? What do I want to get out of this? And perhaps the specific behaviors that are recommended to them as part of the program, they don't have choice in, but they do have this strong feeling that they've chosen to be there. And then Kumanu is a company that was founded by Vic Strecker, who founded Health Media, the startup that I worked for. He's also a professor at the University of Michigan School of Public Health, and he's very interested in purpose and story. And so after Health Media, he created this company, Kumanu, and their app Purposeful is really about helping people think about their values, their identity, you know, who are you when you are your best self? And then instead of it providing you with like nutritional advice, for example, or anything like that, it's more like a meta guide to your day. You know, are you behaving in a way that your best self would behave? So a couple examples of things that that do that. I do always like to talk about value consistent framing, because I talked about bringing behaviors in line with what people value in those autonomous forms of motivation. I used to work with a clinical psychologist who was so good at this. I feel like I sound cheesy and terrible when I try to pretend to be him, but he, you know, he would actually provide therapy to people. He was trained as a clinician, which I am not. And he would say, so, you know, it seems like you're a great dad. I can really see that you value that. Like, look at all the time that you've spent with your kids and all these great things that you're doing. What is up with the smoking? Like, that just doesn't seem to fit. And, you know, creating this dissonance for people, this sense of, oh, geez, yeah, I'm doing something that really doesn't fit this other treasured identity. You have to be very careful with doing this. And I mean, that example doesn't translate well to digital, because you have to have, I think, that trust and rapport and relationship. But it's an example at a high level of what we sometimes try to do by helping people to see when a behavior might support what they're trying to do. We do this a lot at Lirio with our messaging. You know, getting these screenings is going to help you be there for your family. It's going to help you, you know, live your best life, which I really believe is true. But the more we can do that, I think the more that we can help people adopt these behavior changes. I'll quickly touch on a couple of things we can do for helping support competence. So I have been using this slide for like 13 years because it's still the best example I have. Video games do so much, so well with supporting competence. And what I like to, this is from Rock Band, and they do two things here, right? They're giving you your moment by moment score. You know if you've hit the note properly or not, but you also see your overall score, and you have your multiplier if you have streaks. And seeing those two things together is so important, because moment to moment, you need to know in a timely fashion if you're successful, because otherwise, how are you going to get better? Like if you find out 10 minutes from now that you didn't hit that note, you've forgotten. So there, you know, it's not useful at that point. You do need that instant feedback to change and grow. But it can also be really demotivating sometimes if you're struggling. So if you're a beginner, or if you have fallen off, I should probably stop saying fallen off the wagon. I know it has its roots in substance use, but gotta be me here. If you've plateaued, for example, so weight management, weight loss, it's really, really common and normal to plateau. You're losing weight and then all of a sudden you're not. And that's so stressful for people who are working really hard at their goals. So reminding them in that moment of how far they've come can just really be helpful at making the moment-to-moment feedback palatable. So I take a lot of inspiration from the way video games deliver feedback when I think about how we might deliver health feedback. Is there a way that we can make it interesting, supportive, maybe even feel a little bit fun, even though typically health isn't something that is very fun. So I enjoy that. By the way, I have a Peloton. You can probably see the seat of my Peloton in the background here. And I just yesterday, for the first time, tried the game that's on there. It reminded me a lot of like Rock Band. You move from lane to lane by changing your resistance. So I think Peloton's also knocking it out of the park in these sorts of engaging designs. Another thing I'll say too is helping people with feedback. It's not always helpful to just throw the raw numbers at people. And especially again in healthcare, we're not all physicians. We don't necessarily know what these lab values mean or that kind of thing. So the more that we can create sense of it, the more helpful it can be. And there's a product that I really like for how they do that called Shape'a. Dan Ariely is part of the advisory board for this, but it's a scale. And as you can see, it doesn't have a dial on it. So you step on it and it doesn't actually give you any direct feedback. You have to have this app. You have to actually use it for like 10 days before you get any feedback at all, which is a little frustrating. But then after that, you just get a color every day. And the reason for this is there's a lot of research that if you want to either lose weight or keep weight off, weighing yourself every day is really highly correlated with success, but people hate it. And there's lots of reasons why they hate it. A big one is that your weight can fluctuate a lot for reasons totally outside of your control. You know, it could be your menstrual cycle, or you could have eaten something salty, or if you had a really intense workout, you might be retaining water. All of these reasons stop people from doing this weighing themselves behavior. And so the idea is, what if we just told people if there was a significant or meaningful change? So we're not going to bother them with the fluctuations. That green means you may not weigh exactly what you weighed yesterday. You might weigh a little bit more, but it's not statistically meaningful. Like it's basically in the same range. And so what they found in some of their research around this is it does keep people weighing themselves longer. So it seems to work. People use it longer, and then they actually lose more weight when they're using this sort of scale. So I think that's a really nice example of how you can manage feedback in a way that helps people stick with something. And then just lastly, I'll quickly talk about one or two ways that you can support perceived relatedness. And I will say one thing people often assume, sorry, Raphael, what do you?
Yeah, just a quick question. Are like negative or scare tactic type messages something that you try to avoid at all costs, or do they work in some situations?
We don't try to avoid them at all cost. We try to be very artful with them though. So there is a theory, I mentioned before, a lot of theories fall out of vogue. There's a social psychological theory called terror management theory that was popular in like the 90s, and no one ever uses it anymore. And I sometimes think that we should maybe bring it back, because its basic tenet is if you scare people, they disengage. So it's like an ostrich in the sand sort of situation. Like, oh my gosh, I don't want to deal with that. And there's all kinds of examples of how that happens. People who have very serious health diagnoses, for example, and it's too much emotionally and informationally to deal with, may just live as if they don't know that. So yeah, being heavy-handed definitely backfires, but at Lirio, one of the message types that we have the most success with is something called anticipated regret. So it's really framing it up for people like, if you don't do this screening, you might not be happy with yourself a year from now or 2 years from now, because you would have had an opportunity to get ahead of something that's potentially pretty bad for you. And I'm paraphrasing there, of course. We have professional content writers who've done a lovely job, I think, getting the wording just right. So I think that there is a role for it, but it has to be really carefully done. Yeah, Jason?
Just sorry, was typing off exactly what you said about the anticipated regret, but I guess I have a quick question just around your thoughts on the difference between scarcity and anticipated regret. So scarcity is always kind of built on that idea about that fear of loss. And it strikes me that they're kind of related, but not related in a way. And I'm just wondering if you got a good way to describe the difference between anticipated regret, fear of loss, and scarcity, and how those things might fit together or not.
Yeah. And actually, one of the things that we've encountered too, because we also keep documentation on all of the behavior change techniques we use and like how we use them. This is an example. And endowment effect is related to that as well. So the idea that if you have something, you value it more than something you don't have, the identical item that you don't have. So scarcity, I think of, that there is a limited amount of something, and that makes it more desirable for you. We have leveraged that in only one of our interventions, and it is definitely out of date now, and that's our COVID-19 vaccination intervention, because we launched that in March 21, but right when those vaccines were first becoming widely available, and it was still difficult to get a vaccine appointment. So if you remember, it was going out like starting with vulnerable people and then older age groups. And we leverage scarcity effect initially with that intervention, but otherwise we don't really use it much. Anticipated regret is, I guess, sort of related to loss aversion or fear of loss. We try not to frame it quite that way, more like you're going to regret, your life in the future will be better for having done this behavior, and you don't want to look back and be sad that you missed this opportunity. Where if we were to use fear of loss, I think it might look a little bit more focused on why you would regret that in the future. So, you might have lost some of your ability to do the things that you enjoy. We don't actually use that one.
Sorry, can I just ask one question? Just your thoughts. We work with injured workers and people just trying to get them back to work with the recovery. And we do ask a question of them, which is, what concerns you the most about not returning to work? And it's really about them to give this thought about, rather than being stuck in a disability paradigm, that I can be thinking about returning to work. What would my life be like if I didn't? Like, what would be that natural consequence? And I'm just curious what your thoughts, A, on the question, and B, does that really lend itself more into that anticipated regret, or how does that kind of fit in?
Well, I'm sorry, I have such a pedantic answer to that question. Natural consequences is one of the BCTs on the 93 behavior change techniques list, and we do use that one. So yeah, now that you put it that way, we don't label it as anticipated regret. We're able to sort of work within the two. This is one of the things though that's really fun in the design. So we have what we call a manipulation check after we design our content, where our behavioral designers who don't know what is behind each piece of content go back and rate it, and they try to identify what is the behavior change technique. And so often towards the end of our design process, we find ourselves debating, similar to what you just did, like, is this really is this one really anticipated regret, or is it kind of natural consequences? And so there's this sort of additional step at the end to make sure that whatever we're doing with our design is accurately reflecting the underlying technique or approach. All right, rapid fire here, perceived relatedness. People a lot of times, by the way, assume that this means that you have to have like connection with another human being. It's gotten better in my career, but there was a period of time where, first of all, everyone wanted to gamify everything, and half the time they didn't really know what gamification was. But also like, oh, should we put in social media? Should we have social networking involved in our program so that people feel supported and related? And you can do that. There's all sorts of examples of great products that include a true social component and to great effect, but it's not always the right tool to reach for. And there's lots of things that you can do to help people feel connected to each other without without necessarily involving other people. So one is personalization. And this is one that I really deeply believe in myself. I've chosen a couple different roles over my career where I have had the opportunity to specifically work on personalization, including Lirio. And these are a couple examples of just broadly available consumer products. I mean, Google retired Google One. I think that's what it was called. I loved that thing though. It was a little widget on my smartphone, and it knew so much about me. Like this is probably from 2014 or 2015 now, but someone can probably figure it out from what the Facebook stock cost. But it knew that I wasn't at home and I was probably getting home, and I was probably getting there by walking, and it knew which sports teams I was following, and it would just surface up this information for me in a really convenient way. And I did feel very recognized and known by it. And then Siri and Alexa, they learn to interact with you as well. And all of those things make people feel like, oh, hey, this technology recognizes something about me. Spotify too. And I did not include Daily Mix 1 and 2 because I use Spotify to work out, and I have a lot of poor taste in those moments. But sometimes I listen to good music. Those sorts of personalization tech things, when someone feels seen and recognized for who they are, it doesn't matter if it's another person who's seeing and recognizing them or technology. The effect is still, I matter. I have a connection. And I am out there making this connection in the world. So personalization done well can do a really good job there. And then related to that, responding. So if you're building technology, having it be responsive. So this is sort of a riff on personalization. But Cake is a great company. They're based here in Boston, and they help people with end of life planning. So, difficult topics that people don't usually talk about in advance. And they've done this really nice job of creating a friendly, intuitive online experience that helps people feel like their concerns are being heard, and they're being delivered a service that supports them. And then Noni here, this is from 7 Cups. So it's a chat bot, but right away it starts using my name. And I will tell you, I'm notorious for saying using someone's name is not personalization, but it's part of personalization. And they give you choices all along the way to customize what this experience is like. And then they honor those choices. That's the other thing where we sometimes fall short with technology design is we ask people's preferences and then we don't honor them, or we revert back to our own preferences at some point in the experience. And people notice that, they notice that I set this up a certain way. I asked for something and it's not coming to me. So we can help create that sense of relatedness and relationship if we honor what people are asking for. So I will stop there and see what people are interested in talking about. And if anyone does have to leave, this is my email address and my Twitter handle. I'm happy to engage virtually as well. Although you're going to have to, I'm getting slower and slower at responding to email, but I will do it eventually.
Brian?
Hi, Amy. Thank you for all this. Very good, interesting information. Kind of going back to those barriers that you talked about, I would assume that like private information kind of contributes to those barriers and kind of gets in the way of kind of changing behavior. So I guess, how do you deal with people who maybe present themselves altruistically on the surface, but are really more self-welfare, kind of self-maximizing individuals? Like, how do you uncover that information in kind of your line of questioning?
Yeah. One of the things that I really like when I'm doing research is, if I can, doing more than one modality, because I'll even say people who are well-intentioned don't always represent themselves fully accurately. Like we all, have a desire to be likable and to put ourselves in a good light. We may misrepresent our behaviors and our stories to make ourselves look better. And so the more that we can look for other sources of information, the better. I've told this story a lot. I did a project when I was with MadPow around construction worker safety behavior, because data shows that serious injuries haven't declined at all in like 30 years, even though safety technology has really improved and safety training has really improved. And we were interviewing construction workers, and what we wanted to understand is, why would you take risks? Like, why would you ever do anything not completely by the books where you might get hurt? And of course, everyone's like, oh, I would never. So there were two things that we found helped us to really understand. One was asking them to tell us a story about someone else. When have you seen someone else take a risk that they maybe shouldn't have? What do you think was going on there? We would first of all get some good information from them about what they thought other people might be thinking. But then a lot of times when we didn't react badly to that story, they would then go on to open up and say, actually, this one time I also did something a little foolish. So it was sort of like an icebreaker that would help them get there. And even if not everyone did get there, the ones who didn't would still almost always have a story about someone else. And that in itself was useful. But even more than that, we got to spend time on the construction sites. So we got to watch them work, steel-toed boots and hard hats on us. And yeah, no, they were taking a lot of safety risks. And being able to see how they actually behaved in contrast to what they were saying was really helpful too. It's maybe not quite as perfect as hearing the truth about what's going on in their minds when they're making these decisions. One of the things we saw several times, ladder, that like triangle shaped ladder, people standing on the very, very top of it. You're not supposed to do that. You're supposed to stand a couple of rungs lower so that, you have support for your lower legs. And a lot of people would stand on the very top rung, and that's pretty dangerous. It gave us some examples to talk to when we were doing the interviews. Hey, I was walking around, I saw some people were doing XYZ, like, tell me about that. But yeah, if we had just gone on the initial stories and we had relied on people to tell their own stories without asking about others, we never would have known. Mm-hmm. With the stuff at Lirio, one of the things that is also kind of cool is we do our formative research and talk to patients and kind of build our approach in our libraries. But once we're out with a product running, we're not actually directly talking to people anymore. And so we don't actually have to figure out, is this a person who's a self-maximizer, or is this a person who's altruistic? To the extent that that's built into the library, the AI will start to match people with the right type of message for them.
Great, thank you.
Yeah. Benjamin?
Hey, Amy, great talk. I'm also a Wolverine, so go blue.
Yeah, go blue.
I got my master's in user experience from there at the School of Information. I feel like what you talked about had a lot of impact in what they did there. My question was about some of the intrinsic issues that, like, when you want to have someone want to do something because it feels good and they want to do it, how do you have questions about something that doesn't feel good, like, say, going to chemo, but they have to do it and it feels like crap? What is that? Is that still an intrinsic motivator, or is that something else?
No. So there's things you can do. One thing that goes back to that motivational tradition is reminding people of the purpose. Like, you're doing something now that feels like crap. It's terrible, but ultimately this is getting you to something you value even more than feeling good in the moment, right? You want to be healthy. You don't want to have the cancer anymore. So that's one tactic. But one other thing that I really like, and maybe chemo is not quite the right example for this one, but Katie Milkman, who's at University of Pennsylvania, and wrote a great book called How to Change. In some of her research, she looks at something she calls temptation bundling, which is if you're doing something like for your own good. And the example that she's done a lot of her research on is going to the gym. a way that you can make it more palatable, get yourself more interested in it, is to temptation bundle, to pair it with something else that you do really enjoy, and you only get that other thing when you're doing the hard thing. So in a lot of her research, I think she had people listening to like Real Housewives podcasts, and they could only listen to them when they were on the elliptical machine. And she found it made a really big difference in their interest in doing that elliptical machine behavior, which, you know, they didn't like. This was not your chronic exercisers who really enjoy being physically active. This was like people who were trying to develop a new exercise habit, which is notoriously terrible. So that kind of approach too, you know, can you give people some other source of pleasure, something else to enjoy while they're doing the hard thing, I think is a really interesting tactic. And she's doing just some wonderful research on different ways to bring that to life.
That sounds like coercion, but it's more just like a friendly carrot, right?
Well, it's self-coercion too. I think people, maybe not in the confines of an experiment. So if I were going to use this in my work where, you know, my current product is very messaging based, what I might do is say, you know, okay, Amy, you have to go through chemo. Here are some tips to make it easier for you. You know, save your favorite podcast for times when you're getting your infusion. Like, you know, give people some advice and some guidance around that and let them self-choose what that temptation bundling looks like for them.
For sure. Thank you.
Yeah. So Giovanni?
Yeah, Amy, great presentation. Lots of great information here that's actionable. And what I wanted to talk about, you know, and ask a couple of questions about was specific to the solutions that you had to your barriers, right? So on that slide where you had all of your solutions, you know, that were tied to capability, motivation, and opportunity, it looked like, you know, to me, it kind of like a value stream mapping, right? So it's easy to understand and you know exactly how those solutions are tied. But my question was, you know, specific to the actual barriers, because you showed that, you know, whenever you work with a client, you may identify X number of barriers, right? And then you simplify those barriers into constructs. Are those constructs that you came up with, are they pretty much universal, and do they change at all?
This is the slide that you're talking about. So just to.
Yeah, so, you know, when you're working with somebody, right, you have 24 unique barriers, you know, which is great, but now you're able to simplify all that, which is awesome, because now people can understand it and you can take action against that. Is there a lot of change across all of those constructs that you see?
Yeah, so when we simplify to 11 barrier constructs, that's more of a behind the scenes thing. We still create at least 24 different messages or message combinations to address each of those unique barriers, because we want to be able to personalize. So fears, emotions, for example, like that may come from different places. You might be and I'm sorry, I don't have the actual content in front of me right now, but you may be afraid of the procedure. You may be afraid of the results of the procedure. Or you may have emotions because you have a family history of colorectal cancer that is changing the way that you think about the procedure. And so at the high level, like when we're talking to a client about what does this program do, what do we address, it's really useful to have the 11 barrier constructs and be able to kind of just summarize it a little bit more cleanly. But when we're building, we actually do go back to that 24 unique barriers. And the way that we do the research, we really try to make sure that we're capturing a broad set, so that if we were to bring this to any group of people, there would be at least one thing in that library that worked for each person in that audience. So one of the things that we pay a lot of attention to is we want to make sure that we're getting research that captures unique populations. Like sometimes you'll find that there's research around health behaviors that's specific to Medicaid and Medicare recipients. And we want to make sure we're including those things, even though you know, there's other environments that I've worked in where you may say, okay, that's a group of people who probably aren't using our technology. We don't need to worry about them as much. So the idea is, yes, as a whole, it would be universal, but that doesn't mean that every single piece of it works for every single person, if that makes sense.
Yeah, thank you.
Yeah, you're welcome. Mia?
Hi, thank you for your talk. I have two questions. My first question is, do you know of any behavioral design firm or researcher who've worked with court systems in the United States?
Oh boy, not immediately. I would look perhaps at Ideas 42. So they're a behavioral research firm that does a lot of more like civic government related work. So I wouldn't be surprised if they do that. And then there's a website called BHub. Hold on, I'm going to quickly see if I have this. Yeah, bhub.org. I'll throw the link in the chat. They have lots of case studies of particularly more like civic behavioral design projects. And so you might be able to find something there. And then, yeah, there are government nudge units. The other place I might look is the Behavioral Insights Team, or BIT. So they have a North America firm that, they're global, but again, like really focused on government and civic work. And so I wouldn't be shocked if BIT had something related to that. And by the way, BIT, Michael Halsworth and Elspeth have written a wonderful book on behavioral design that I actually bought for everybody on my team. So really recommend their work too.
And then my other question has to do with, so before we had apps and artificial intelligence, as we're now referring to it, humans must have been designing things to impact behavior before we had apps. Is there anybody who's done historical research applying the behavioral design, but looking backward to different civilizations?
Oh my gosh, I don't know, but I would read that in a heartbeat. Yeah, I don't know. So there's people like, I think it's Andrew Solomon wrote a book called like Far from the Tree, that for some reason, I mean, it's one of those, really thick books where he looks at all different sorts of issues in history through a modern lens of like how inheritance works, heredity. And I feel like an author like him might try something like that, but I'm actually not familiar with anything like that. I think that would be so cool. Not my next book project. I've got my hands full. I will look though. If I see something like that, maybe I'll email Raphael and let him know.
Yeah. I think Gabriela had a question. No?
Yeah, it was a pretty silly question. I mean, I can ask it if you want, but I think it's kind of a silly question. So when you are designing things for behavioral change, clearly, if people start having tests for serious illnesses, one test is considered a success. But if you're designing things to change people's sort of lifestyle habits, like exercise, for example, you talked a lot about measuring outcomes. Do you measure persistence of outcomes? I mean, what counts as a success here?
Yeah, well, I'm sorry, this is such behavioral science answer, but it depends. It really depends on the context. It's very typical to choose an endpoint, and that would be the term you'd see, endpoint for the research that somehow aligns with your goal. So a lot of times you'll see something like 6 months after they first started using my product, if this person is still exercising at least 3 times a week, we will consider this successful. I would say those endpoints are sometimes somewhat arbitrary, either based on what previous research has used, because you want to compare your product to something that's already out there or some approach that's already out there. And the easiest way to do an apples to apples comparison is to have the same endpoints. But I mean, it depends. Like if my product is about teaching someone to do something, maybe all I need is a demonstration that now they know how to do it. Where if it's about, instilling a new lasting exercise habit, that's when I'm going to want to come back in 6 months, 12 months and actually see what are you doing? How often are you doing it?
So as a follow-up, how long does it take to make a new behavior a habit?
Yeah. And you know what? The research, there's no answer to that. I know that there's this, what is it, like 30 days to a habit. There's some number that gets bandied about. And even like Malcolm Gladwell's 10,000 hours to expertise, like, no, it really varies. And you think of it like an easy behavior, you don't need 10,000 hours to become expert in it. A really hard behavior, 10,000 hours may not be enough. Or like, if I pick up the violin, there's no amount of hours I'm going to spend. I'll never be a prodigy at it. That's just not something that I have the innate skill or training to do. Yes, Raphael just put in the chat, Wendy Wood's work. Wendy Wood is where's she, NYU?
She's on the other coast. I think it's
Okay.
USC or something like that.
Oh yeah, Wendy Wood. I mean, she obviously publishes a lot of papers, but she actually had a book come out maybe a year and a half ago that's very good about habit. And I actually think some of her work, it speaks to the fact that there's no like magic number of days or time that it takes to build a habit. So Yeah, and I mean, you see relapse all the time too. There's a model of behavior change that people are often familiar with called the trans-theoretical model, or stages of change. And a piece that sometimes gets dropped out of it is there is a relapse stage in there. It's like expected with a lot of behaviors that people occasionally relapse, and they may need to join back up at an earlier stage of change. So it does vary a lot, but I think what's important is, making it easy for people to fail and to come back.
I have a question on, I thought Gabriela's question was really good. How do you help people figure out a goal that makes sense for them? Because I know that if you're running an exercise app, of course you're going to want to look like a swimsuit model and Sports Illustrated and all. I get that. I know that's where people's head is at when they're on the phone clicking around. But how do you say, okay, you're starting at 250 pounds and in 6 months, based on having a normal life, where you want to be at? Like, how do you work with people on that kind of problem?
I skipped this slide, but and again, I'm mostly working in digital, so I don't have the opportunity to have a conversation with somebody and say, hey, that might not be realistic. But this idea of goal scaffolding is really important. And Duolingo is not a health tool, but they do wonderful behavioral design. The end goal of learning a language, that's like losing 250 pounds. It takes a really long time. And even if you make really great progress, it's going to take a really long time. And so the more that you can break it down into meaningful milestones, meaningful sub-goals, that's how you can help keep people interested. And it does, especially with something like weight loss, because that's also like, it's just such a personal thing for people. The reasons why they might do it are so bound up in their emotions and their identity that it can be very hard to keep people oriented on the process when they really just want to get to the goal. But this is one of the tools that I rely on in designing for digital, is really, okay, we're not looking at the destination. We're looking at the next way stop on your way. And we're going to congratulate you every time you reach one of these milestones. We're going to really try to make sure that you understand that this is significant and that you are doing a good job. Because otherwise, it is really, really hard. And especially when people are aiming for something like, again, similar to how I'm never going to play a violin. There have been times in my life where I have been very fit. I have no one has ever asked me to be on the cover of a magazine in a swimsuit, and that's fine. But goal scaffolding is where I probably would go first.
Amy, so a question I had is, a lot of what you have discussed here is predicated on digital, right? Digital means. Now, doesn't that create, say, more of a barrier between people who are digitally savvy and, say, senior citizens? I mean, would this create more of a dichotomy in that sense?
Well, so one thing that senior citizens are more digitally savvy than most people realize. So Pew Internet Research does a lot of surveys of technology use among different demographics. And especially as time goes on, you're seeing elder folks use technology quite a bit. At Lirio, we mostly use text message and email. And one of the reasons that we've chosen those channels is they have really good penetration into older groups of lower income. Most people, even if they don't have a laptop, will have a way to receive a text message. So trying to think about digital in ways that are maybe not as exclusive. It's not, it's not a panacea. I don't know that there's any intervention out there that works for truly everybody, but I think older adults are probably more on technology than you think. And as long as you're not doing something that's like an Oculus-based intervention, where you're really targeting your upper income and probably slightly younger people, you might be surprised at how good penetration is.
Any more questions? Okay. Thank you so much. Thanks everybody for coming. And thank you, Amy. This was a fantastic talk and session. I think we just learned a tremendous amount from you and from your talk. And everybody, don't forget the book. Okay. But thank you again, and stay tuned for our events in general.
Thank you all. I really appreciate all the questions and your attention. This was really nice.